All right. Well, it is 9 o'clock, and gentlemen, we are back after a couple-month break. So it's great to be back. Those of you who have joined us, this is Steve Kershke. I have Dr. Jeff Snell and Don Terry today. Jeff is usually in the studio. Jeff, I miss you today in the studio, but very glad to have you remotely signing in from Virginia.
Yeah, I know, a little different than sitting across the table from you, but yeah, I can see you. So,
I know
it
we can
works.
see each other, and we're just glad to still have you, but we miss having you on campus. Don, thanks for joining us as well. Those of you who have joined us remotely, this is our monthly webinar. If you're familiar with QLI and our webinar series, welcome back. Those of you who are new to QLI is a post-acute brain and spinal cord injury rehab facility based in Omaha, Nebraska. We sit on about 70 acres of land. We have a campus post-acute style program, and we have the good fortune to work with quite a few folks from all around the country. And related to that, we have quite a bit of talent in-house to put on this webinar series. And so if you've, again, been with us, Jeff Snell is no stranger to you. But Jeff, we're really glad to have you speak on the topic of alcohol and brain injury today. And you and I are talking a little bit about, you've done this presentation once before, but I actually haven't heard it myself, so I'm excited to hear it.
Well, great. Hopefully you'll enjoy it.
Yeah, so before I kick it over to Jeff, one big piece of housekeeping, and it's Don and I's goal that we could get through a webinar and have 0 questions about CEUs. Don, do you think it's actually possible?
I'm hopeful.
This is a big piece of information, though. So we do have a poll question that will be launched at the very end of Jeff's presentation. There's only one of them, and that is the poll question you need to answer in order to get your CEUs. Additionally, we will use that to send you a thank you email immediately following or closely following. Usually it's within the next hour or two following the presentation, which we're all queued up for today. And in that, you will take a survey, and as a result, that survey prompts the CEU certificate that you will need. We do CEUs for case management only, so adjusters, if you're on board, this is your forewarning. There are no adjuster CEUs. We apologize for that, maybe someday in the future. So that's the housekeeping. I will remind you all one more time at the very end. But with that, Jeff, it's over to you, and would love to hear what you have to say on the topic, and we'll jump in with some commentary along the way.
Yeah, wonderful. If you do have questions, please toss them in the chat. Steve, Don, if y'all could monitor the chat, and if there are things that come up, let me know. I would love to address them as we go through. So the presentation that we are going to go through today regarding alcohol and traumatic brain injury, the major points that I want to hit as we go through. First and foremost, just the effect of alcohol on the body and brain, and this is independent of brain injury. This is just how does alcohol affect us? Why does it have the effect that it does? Talk a little bit about the bidirectional relationship between alcohol intoxication and TBI. That moves in both directions. The risks associated with alcohol use following TBI, so specific to our clinical population that we focused on. What is the prevalence of use following TBI as well? And then recommendations, and those recommendations are likely to be something that you can predict if you look at the next point, which is ways to change, cut down, and stop drinking. So the recommendations regarding alcohol use right off the bat are going to be that alcohol after TBI is not a great idea, and we want to do what we can to minimize that. So first and foremost, how alcohol affects the body. So when we consume alcohol, we swallow it, but it doesn't go really through the same digestive process as food. A small amount is immediately absorbed into the bloodstream by the lining of your mouth and stomach, and the remaining amount of alcohol that is in there is going to be absorbed rapidly in the small intestine. So in normal circulation, this results in alcohol rapidly perfusing throughout the body. In around 90 seconds, the immediate effect begins. It also crosses the blood-brain barrier, and these are extensions of glial cells, astrocytes that surround the arteries bringing blood into the brain, and they prevent a lot of larger things, bacteria, from being able to cross that barrier. It's a protective barrier for brain tissue. But alcohol has a very, very, very small molecular structure, and it's able to cross that barrier very efficiently, very effectively. Alcohol is also a central nervous system depressant, meaning it decreases activity within the CNS, and the effect that it produces relative to our mood, our cognition, our physical functioning, that reflects the degree and order in which neural circuitry of the brain responds to this CNS depressant or lowering of neural activity. Now, the body immediately begins to metabolize or break down the molecular structure of alcohol into non-harmful substances, water, carbon dioxide, and also generation of energy-producing molecules. Around 10% of alcohol is eliminated through sweat, breath, and urine. The remaining 90% gets broken down by enzymes in your stomach and liver, and that occurs at a relatively constant rate of about 1/2 ounce per hour. Now, that equates to around half of a standard drink per hour. So if you drink more than 1/2 ounce per hour, the level of alcohol in your bloodstream will build up because it can only break down about 1/2 ounce per hour. As it builds up, it has more detrimental effects to our central nervous system. If you continue to raise that level, as that level becomes dangerous, there are some built-in mechanisms within our central nervous system to deal with that. One is vomiting. So again, emptying the contents of your stomach out so you don't have the alcohol in there for it to absorb. The other is a loss of consciousness. If you drink enough quickly enough, that is basically a defense mechanism against further damage. You can, however, consume alcohol in large enough quantities in a short enough period of time. Again, this is binge drinking, taking multiple shots, drinking games, something that you might encounter with that. If you drink enough in a short period of time, these life-saving automatic responses can't stop the blood alcohol level from climbing quickly enough, and that's where you get into issues of acute alcohol poisoning. You'll occasionally see that, particularly on college campuses with hazing type incidents where alcohol poisoning can result from those, drinking, binge drinking incidents. Now, one caveat here with regard to the short-term effects of alcohol in the body, most of these acute effects of alcohol, both positive and negative, are a direct consequence of how alcohol changes the functioning of our brain. So when we're talking about things within the body that are impacted, usually that is a direct consequence of how the brain interacts with that organ or with that behavior. Alcohol is a depressant drug, and due to the ease of availability and social acceptance, it's often abused in the form of binge drinking. It's not unusual to see a person binge drinking as a way of just kind of letting their hair down. However, binge drinking often results in alcohol's unpleasant side effects the following day, something we typically refer to as a hangover. The more alcohol you consume, the more unpleasant and the more lengthy the aftermath of that recovery can be. Another piece of it is, as we get older, we become less tolerant of alcohol's effects. This is because as we age, our vital organs that are responsible for processing alcohol work less efficiently. Lifestyle and general physical health also are a huge factor in the way and the speed at which we're able to rid alcohol from our system. Now, as I said earlier, the short-term effects from alcohol can be felt within less than minutes, seconds, typically about 1.5 minutes of consuming your first alcoholic drink. The degree to which you feel these effects are also influenced by a host of different factors. So age, gender, purity of the alcohol consumed, how much your hydration level at the time that you begin drinking, whether or not you've recently eaten. Genetics play a role, general physical health, and then a big one, particularly after injury, any medications that you might currently be taking. All of these are things that can impact the effect that alcohol has. So all of these things you see listed on this page, kind of a progression as well of things that alcohol affects. Changes in smell and taste and appetite, blackouts, unconsciousness, coma, death, again, far end of the spectrum. But these are all acute short-term impacts of what alcohol does. Now, there are some positive health benefits to mild to moderate alcohol use. So I wanted to give you both sides of the coin here. It is not all negative. The reason that I put this up here is because there are positive effects. The reason the recommendations for women with intake relative to men, as we're going to talk about a little further on, mild to moderate alcohol use is generally defined as up to 1 drink a day for women and no more than 2 drinks per day for men. The reason there is a gender difference in recommendation there is that women typically absorb about 1/3 more alcohol into their bloodstream than men because they have less of a metabolizing enzyme, something called alcohol dehydrogenase. This is the enzyme that breaks down alcohol in our stomach and small intestine. The gender difference here makes women more vulnerable to the effects of alcohol because it is not broken down as quickly. So a recommendation for mild to moderate use is going to be less alcohol intake for women than it is going to be for men. Now, the positive effects of alcohol that you see here, reducing the risk of developing and dying of heart disease and the potential reduction in risk of ischemic stroke, those first two largely have to do with the blood thinning impact of alcohol. As I said before, the molecular structure of alcohol is very, very small. If you take a glass and you fill it with water exactly up to the point that if you put another drop in, a drop falls out, completely fill the glass with water, you can then add a small amount of alcohol without overflowing the glass because its molecular structure allows it to fit very nicely between the molecules of water, between the H2O. So because it is such a small molecule, it also acts as a very good blood thinner, and it fits within the bloodstream as well. So as you drink more, you're actually intaking a very effective blood thinner. There's also a potential reduction in reduction of diabetes. Now, the big thing here is having a healthy diet and being a little physically active gives you these and many other health benefits without all of the known risks that you just saw. So this is directly out of a medical journal. This is not my personal opinion. This is a quote. Because regular alcohol use is harmful to health in so many different ways and also puts us at greater risk of violence and accidents, encouraging alcohol consumption is a poor preventative health measure. In other words, physicians, you're likely not going to find a physician who says you should drink more because of those those harmful issues associated with it.
Jeff,
Yes.
I was thinking that beyond CEUs, we were going to give permission to have a drink of alcohol per day, but it feels like you're saying there's lots of other ways to get those effects. So even that's off the table. Yeah,
it is. And particularly, and as we'll talk about here in just a few minutes, particularly after you have had a brain injury, that really should be off the table. But it is a decision that every person has to make, and I think it needs to be an informed decision. So that informed decision is there are some potentially possible positive effects, but those effects are more easily gained by things that don't cause all the problems associated with it as well. Now, the greater number of effects that alcohol has on the body that are associated with long-term or chronic use of alcohol, this is really where you get into the negative physiological consequences, these more long-term effects. Drinking heavily over prolonged periods of time carries many risks, both to the body and mind. Some of these risks can't be reversed just by quitting alcohol. For example, where damage is sustained to the liver and brain through excessive alcohol consumption, a person's quality of life can be heavily compromised. There can be long-term metabolic changes to the brain that are irreversible in nature. Now, even light drinkers, those who consume no more than 1 drink per day, have a small but measurable risk of increase of several different types of cancers, particularly those associated with esophageal cancer, stomach cancer, and also have known risks associated with unintended injury. Now, that's one of the biggest ones when it comes to alcohol use, and one of the biggest risks is that of unintended injury, accidental injury. The increased risk of suffering an accident, such as a fall, a burn, a car crash, these are much more likely when individuals are intoxicated. There's also a much greater risk for domestic violence and sexual assault when individuals are intoxicated. There's also, again, this is one that you don't get outside of alcohol, there's an increased risk of suffering from alcohol poisoning. You can't get alcohol poisoning if you don't drink alcohol, but that's on the far end of the spectrum that we talked about as far as the risks.
Jeff, we have a quick question.
Yes,
This is
please.
back to the positive impacts and maybe even the negatives, but does the type of alcohol matter, or is it pertinent to achieving the positive impacts? I think if I'm reading the question right, it's, does beer compared to wine matter in terms of the positive impacts? And then, maybe on the negative side, anything to consider there?
Well, again, it has to do with the proof of the alcohol. So in other words, the proof refers to how much alcohol is in a given substance. So beer, the proof of beer typically is much, much less. It's usually, single digit percentage, as opposed to something like a bourbon or a whiskey, which is typically going to be around 80 proof. Grain alcohol that you can buy that's 180 proof or better. If you take proof and divide it by 2, roughly that is the percentage of alcohol in that substance. So 200 proof alcohol would be 100% alcohol. So it is how much alcohol is in the drink itself rather than the drink as far as the risk that goes along with it. So you're going to get more alcohol more quickly with a higher proof drink. So if you're drinking whiskey, for example, an ounce or an ounce and a half of that is going to be the equivalent of 12 ounces of something like beer. So there's a big difference there in terms of just how much alcohol is in the drink per day, in the drink with proof. A couple of other things I just wanted to mention briefly on this one. There's the vitamin B1 deficiency and malnutrition that's listed there toward the end. Alcohol actually prevents absorption of some vitamins and some nutrients, and so that leads to depletion over time. So B1 deficiency is common with heavy alcohol use because of the amount of interference of absorption of this vital vitamin that can lead to, again, all kind of secondary problems with brain function as well as other physical functioning as well. Now, I mentioned earlier that a lot of the effects listed in earlier slides, particularly when talking about immediate or acute effects of alcohol, these tend to be a direct consequence of how alcohol impacts the brain. Alcohol acts directly on many areas of the brain, changing the way the brain functions and communicates. Again, because it's a central nervous system depressant, you can think of it as dialing down or depressing action in various parts of the brain. Now, again, think of depressing action as kind of making that particular function work less efficiently. So think of that as well with an analogy of a car. If you make the accelerator pedal less efficient, then when you press on the gas, it's not going to go as quickly. It's not going to react the same. Same thing for the brake. And that's kind of what happens when the frontal lobes start to get impacted. It's kind of like the brakes aren't very efficient. They aren't working very well. There's a danger inherent to how alcohol uniquely depresses brain functioning, and that lies in the pattern of suppression that emerges. It tends to be, from the standpoint of a brain, more the anterior aspects of the frontal lobes get impacted earlier and to a greater extent than the more posterior aspects of the frontal lobe. Now, the very front of our frontal lobe has to do with, inhibition, judgment, reasoning, decision-making, dialing down our impulses, being able to intercept and overrule through our own awareness, impulse actions. The very back of the frontal lobes are much more involved in planning, executing motor function, sending signals out to the muscles in a coordinated fashion to allow us to move. So again, if you look at the more anterior aspects of the frontal lobes, you're looking at attention, initiation, inhibition, planning, decision-making, self-control. We lose these aspects first. Meanwhile, our motor control, although becoming more discoordinated the more we drink, it lags behind in that impairment. If the pattern of alcohol and how it affected the frontal lobes was reversed, alcohol wouldn't present the difficulty and danger that it does. In other words, you would go in, here's the old Western. The guy walks through the swinging doors up to the bar, orders a whiskey, slams it down, and then starts fight, right? That's what happens in a lot of these old Westerns. Well, if the pattern was actually reversed, what would happen is the guy would come sauntering in, he would order a whiskey, he'd slam it down, and his motor function would cease and he would fall down at the bar. So that's not going to be a very exciting, not a very exciting bar fight. It also, again, wouldn't present the issue with us being able to argue with somebody over whether or not we're safe to drive. If the back part of your frontal lobes was affected first, again, after a couple of drinks, you wouldn't be moving. You'd be laying on the floor. So the fact that we have impaired judgment, but we still have motor function, the way in which it actually affects our brains means that it is a huge risk for us. That's why unintended injury is very high on the list of the dangers associated with alcohol. So we're able to move, walk around and talk, but we've lost our inhibition and our rational decision making and our ability to regulate our behavior and emotions. That's a dangerous situation. So communication can be disrupted or slowed secondary to this cortical depression, and it's in turn responsible for our physical and psychological changes while under the influence. So that's why the laws associated with this, you are charged with driving under the influence of alcohol, or DWI, which is driving while impaired. Psychologically, alcohol can have a lot of effects as well, most of which are negative. A common cause of acute alcohol intoxication is binge drinking. Again, it's drinking faster than your body can rid itself of the alcohol. The National Institute on Alcohol Abuse and Alcoholism defines binge drinking as a pattern of alcohol consumption that increases a person's blood alcohol concentration to 0.08 or greater. In women, this generally occurs after about 4 drinks in a 2-hour time span. For men, generally 5 drinks within 2 hours. Anything more on top of that simply increases that level. The effect of alcohol on the brain tends to initially impact the outer layers of the cerebral cortex in an anterior to posterior direction. As the effect progresses, as you have higher levels of intoxication, it begins to impact balance and muscular coordination. These begin to deteriorate. This is where you get the clumsiness, more falls, knocking things over unintentionally, slurred speech, secondary to the reduced muscular coordination of the muscles involved in expressive language. And then you get into more midbrain and brainstem issues. And once you get to the brainstem, this is where things start to go south really fast. Respiratory suppression, minimal to loss of consciousness, loss of some of the basic regulatory aspects of autonomic functions, heart rate lowering, respiratory rate lowering, and dysregulation of body temperature, and eventually unconsciousness. At lethal doses, that combination of lowered heart rate, temperature, dysregulation, and respiratory suppression is what typically results in alcohol poisoning death. As mentioned earlier, this is usually the result of drinking large quantities of alcohol in a very short period of time. And in the United States, this is an average of about 6 individuals per day die of acute alcohol poisoning. 3 out of 4 of those are adults, 35 to 64. And 3 out of 4 are men. So this is much more a problem associated with being male and middle-aged, I would say. Most of the time when we hear blood alcohol content, you think of impaired driving, but there's a progression of impairments that are associated with different levels of alcohol within the bloodstream. And you'll notice that these effects begin to be measurable at about 1/4 to 1/2 of the legal limit. So fine motor coordination is actually one of the earlier things that's picked up on. In the state of Nebraska, blood alcohol content of 0.08 or higher for an individual who is 21 years of age or older is considered per se evidence of intoxication as defined by law. In other words, if you're operating a motor vehicle and your blood alcohol content is at or above 0.08, no other evidence is needed to support a DUI conviction or a DWI conviction, depending on the state that you're in. This is a standard that has been adopted now by all 50 states at this point as well, so that 0.08 is considered per se defining level for intoxication while operating a motor vehicle. There are also different levels typically for those under the age of 21. In Nebraska, that is 0.02, anything at or above 0.02 if you're below the age of 21, because again, legally, you're not supposed to be drinking alcohol below the age of 21. Nebraska follows implied consent laws. And what that means, and most states do this as well, by applying for and obtaining a state driver's license, you are giving your consent to a blood alcohol test if law enforcement officer suspects that you're driving under the influence. So again, that is something that you have to read the fine print when you get your driver's license. That's one of the things. You're giving that consent in obtaining a driver's license. Now, again, for drivers under the age of 21, most states also follow that 0.02 level, but there are several states that have lowered that to anything above 0.0. 7 states count anything above no alcohol in the bloodstream whatsoever as evidence of intoxication if you're below the age of 21. You'll also notice kind of on the upper limits there that the 0.25 to 0.30 blood alcohol level, coma, is generally the result in a non-habituated drinker. Non-habituated means, I don't know, you could almost think of it as amateur versus professional. I mean, if you drink a lot frequently, your body actually accommodates to that. That's where you get into the higher blood alcohol level, where an individual is still able to drive, able to talk, able to move, but has a ridiculously high blood alcohol level. In the US, the highest blood alcohol level ever recorded, I was curious about this when I was putting this presentation together. December 2004, a man drove a car into another car, taken to the hospital, had a blood alcohol level of 0.914. His level was so high that the physicians ran 5 different independent tests, all of which supported that initial reading. Now, again, if you look up high blood alcohol DUI arrests online, you'll find that many exceed 0.4, 0.5 levels that are generally considered to be within the range of causing fatal reaction. But again, if you have habituated your body through long-term chronic use, you can actually obtain a much, much higher blood alcohol level. Not something I recommend. Now, this is an extreme example of the physiological impact of heavy chronic alcohol abuse on the brain, and that is loss of brain volume, a loss in the tissues that make up the cortex and the insula, the midbrain. With this volume loss, it gets filled in with cerebral spinal fluid, and so when you look at a scan, what you see as the image on the right, you see a loss of tissue. Now, as we age, there is typically some small loss of the brain parenchyma, of the meat of the brain over time, but nowhere near what you're seeing, particularly for a 43-year-old there. So that physiological change to the brain reflects severe, often cognitive disruption, motor incoordination, loss of various functions. This is where you're actually going to get diagnosable syndromes associated with the chronic use and the damage that has occurred to the brain. Now, many people realize that long-term drinking can damage the liver. It's the organ chiefly responsible for breaking down alcohol, but many people are not aware that prolonged liver dysfunction, like liver cirrhosis resulting from excessive alcohol consumption, can actually harm the brain. It leads to a serious and potentially fatal brain disorder known as hepatic encephalopathy. In other words, inflammation of the tissue of the brain secondary to liver dysfunction. Hepatic encephalopathy can cause changes in sleep patterns, mood, personality, even psychiatric conditions like anxiety, depression, and severe cognitive effects like shortened attention span, problems with coordination. And in the most serious cases, again, coma, which can result in a fatality. So looking at this it's a secondary process because of damage to the liver. Women are more vulnerable to this because of the medical consequences of alcohol use. Women are more likely to develop cirrhosis at lower levels of use, and also more severe cirrhosis associated side effects and secondary processes because of that decreased amount of the enzyme that is necessary within the body to break down the alcohol that you're consuming. Thiamine deficiency is also a very common occurrence in people with alcoholism, and it results from overall poor nutrition. As I said before, alcohol blocks the absorption of many vitamins and nutrients within the body. And thiamine, which is also known as vitamin B1, is an essential nutrient that all tissues require, including the brain. So people often, if they are admitted to the hospital and seen to be in alcohol withdrawal, part of that CWAP protocol involves administering thiamine, trying to get levels back up to a normal level. Because in up to 80% of alcoholics, a deficiency of thiamine can be found. And that can go on to a more severe brain disorder called Wernicke-Korsakoff syndrome. Wernicke-Korsakoff syndrome is a disease that consists of two separate syndromes, a very short-lived and severe condition called Wernicke's encephalopathy, which includes confusion, oculomotor disturbance, muscle discoordination. But as that progresses relatively quickly, it moves on to a condition known as Korsakoff's psychosis. So this is one of these disorders, syndromes that that really is something you don't come all the way back from. Korsakoff's is a chronic and debilitating syndrome with persistent learning and memory problems, very forgetful, very frustrated, difficulty with walking and coordination. This is all hallmark signs of Korsakoff's. And although patients might have problems remembering old information, it's their difficulty laying down new memory that's most striking. And that's what is kind of common with brain injury as well. I want to go ahead and move forward here into the bidirectional relationship between alcohol and TBI. It's the impact that alcohol use has on TBI and the impact that having had a TBI has on alcohol use. According to data within the TBI model systems, alcohol and TBI are very closely related, with up to 50% of adults who sustain a TBI drinking more alcohol than is recommended prior to their injury. Not necessarily immediately. It can be, kind of daily use. It's not referring here to intoxication at the time of injury, although intoxication does make much more likely unintended injuries, including those that result in TBI. Now, whether this be through risky behavior like driving while impaired or simple discoordination as a result of the neurological effects of alcohol, vestibular dysfunction or slowed or discoordinated motor movement makes us much more likely to have a fall, to have a slip and fall and not be able to recover quickly enough, or impaired judgment and disinhibition to get into a situation that we probably wouldn't get into when we are not intoxicated. The most highly associated type of alcohol use associated with TBI is binge drinking. Again, consuming 5 or more drinks at a single sitting, where individuals are 3 times more likely to suffer a trauma, and TBI being one of those types of trauma. The lifetime incidence of TBI is approximately 4 times higher among individuals who drink alcohol as compared with those who do not. The overall rate of alcohol use disorder is very high among patients who incur a traumatic brain injury. Estimates range from 1/3 to 1/2 of all patients meeting diagnosis for criteria of alcohol use disorder who have sustained a TBI. The population of persons who have sustained a TBI disproportionately consists of individuals who drink alcohol and those who meet alcohol use disorder diagnostic criteria. Now, you remember this slide from earlier. This is the acute effects of alcohol on the brain, independent of whether or not that individual has had a brain injury. So all of us, any of us who drink alcohol, these are effects that occur. All of these impacts are present for an individual who has had a previous TBI as well, with a result in deterioration of central nervous system functioning. So again, for an individual who has a traumatic brain injury and residual deficits that have resulted from that injury, they may already have decreased capacities secondary to the effects of that prior injury. You're now adding additional detriment to central nervous system function when you pour alcohol on top of the residual injury that already exists. Self-regulation of alcohol intake can also be impacted by the cognitive and life circumstances after a TBI. Data from one study noted that approximately 20% of patients who were abstainers or light drinkers prior to their TBI exhibited high volume intake after injury. So for some individuals, there's an increase of alcohol consumption following TBI. Among military personnel, several studies have reported that service members who experienced combat-related TBI were much more likely than those with non-combat TBI and uninjured individuals as well to binge drink. There is a relationship of TBI and drinking present in studies that have looked at the population of individuals seeking treatment for substance abuse disorder. Over 50% of individuals in that population have a history of TBI. Nearly half of those had reported having more than one TBI. So again, a bidirectional relationship. Having had a TBI makes it more likely that we will drink and drink in problematic levels. And drinking, again, increases the likelihood of having a TBI. Younger individuals are also more at risk for developing alcohol use disorder after a TBI. Individuals who have a positive history of TBI have some increased risk for issues that are not common in the non-TBI population. So one of those is an increased risk of seizures. We know that having a TBI increases your risk of seizures. That is both direct in terms of creating the neurological conditions that make seizures more likely. It's also by the fact that alcohol interferes with the effectiveness and efficacy of prescribed anti-seizure medications. So if you have a seizure disorder and you take medication to prevent those seizures, alcohol actually interferes with the effectiveness of those medications. Alcohol also has the potential to present dangers when many prescription medications are present, especially opioids or other narcotic pain medications. In particular, the risk of overdose or death associated with alcohol use with narcotic pain medications is something that can't be underestimated. That is a significant issue. Alcohol adversely affects peripheral tissues, meaning especially the liver and kidneys. It impairs wound healing. So again, a disproportionate negative effect on patients that are recovering from trauma or who have mobility limitations that make skin breakdown more prevalent. That is a bigger risk when you combine that with alcohol. Studies have demonstrated that people with a history of TBI who drink at least at heavy social levels, and they exhibit more event-related potentials. So in other words, this is a measure of neuronal transmission. So event-related potentials, which show that cognitive deficit is actually associated with differences in the speed of neuronal transmission, a slowing of processing speed. Now, if your brain's functioning is already compromised by a prior neurological insult, adding additional impairment by adding a CNS depressant is clearly contraindicated. Alcohol impairs brain function, and if that baseline level of brain function is already compromised by the effects of brain injury, there's a greater degree of impairment that would have been the case with your pre-brain injury baseline status. And remember that some functions of our brain act to inhibit other actions. So in other words, the ability to mediate and modulate other signals within the brain is also decreased. So your impulse control, which is often associated with frontal executive difficulties, and these are common, very common after traumatic brain injuries, this is one of those regulation or inhibitory functions that gets decreased in the presence of alcohol. And emotional disruption in the form of depression is around 8 times greater in the first year after TBI than in the general population. Now, this can be secondary to a lot of different issues. One would just be the primary neurology of the neural network associated with depression. The other would be that the depressant action of alcohol itself. Alcohol can be a central cause of depressive symptoms, or it can negatively contribute to depressive symptoms. It can also interfere with the effectiveness of medications given to treat depression. I think another thing contributing to that 8 times greater in the first year after TBI statistic has to do with the changes in lifestyle, the interruption of ability to engage in those things that are our normal routines that make us feel the person that we are. So when all of these things are impacted and interrupted, an emotional reaction is not unanticipated. Now, these findings speak to the negative impact of chronic alcohol use and abuse following TBI, because in a study comparing subjects with a positive or negative blood alcohol level upon admission for mild to moderate TBI, it was only the severity of chronicity of alcohol use that was shown to demonstrate a significant negative association with cognitive recovery. In other words, chronic substance use was associated with worse cognitive outcomes, and that's regardless of whether that chronic alcohol user had a positive blood alcohol level at the time of injury. So in other words, you don't have to be drunk at the time of your injury to have a more negative cognitive recovery. Simply the fact that you have chronically abused alcohol over time is much more associated with worse outcomes. The fact that it was age-related likely speaks to the degree of chronicity of alcohol use. Again, if you are older, you have probably been using alcohol for longer. Those cumulative effects over the years of substance abuse and substance use even result in brain volume loss, as was shown on that slide earlier. And so the kind of age-related changes that you see with the brain tend to be earlier on in manifestation when you're talking about an individual who has a history of substance use. Now, prevalence in a 2022. Yes.
Quick question.
Yeah.
Related to that, we had a question around, I think this is around like the neuroplasticity component related to alcohol use. So what's the research say around brain matter loss and the ability to to have neuroplasticity after alcohol use, and not necessarily associated to a brain injury, but when you talk about kind of the effects of the brain injury on top of someone who's a chronic user, I think it's also connected to that. So do you have comments on that?
I'm actually going to hold off on that because those are some of the major points that we're going to get to here in just about 10 minutes. So
Got it.
Hang on, it'll come. So a Gallup poll looking at alcohol use in the U.S. and this was done last year. So these are adults 18 and older who report drinking alcohol. It averaged about 63% of the population over the past 2 years. 36% of the population described themselves as total abstainers. If you narrow it down to the legal drinking age of over 21, the rate increases just slightly to 65%. So 65% of our U.S. population drinks alcohol on some regular basis. That rate has been reported as relatively consistent in recent decades. It's a bit of a fall off from 50 years ago, where it was at a high of around 71% of the population. That's still a relatively high percentage of individuals, though, who drink alcohol within the total population. So it's no surprise that similar rates are found within clinical populations. The first data point there refers to a large group study that came out of data from the TBI model systems, and it was made up of over 6,000 adults with moderate to severe TBI. Low-risk drinking in this case refers to no more than 2 drinks a day for men, no more than 1 a day for women. And there does appear to be about a 5% drop in that low-risk drinking over the first year post-injury. Now, why does that drop over the first year? There's probably a lot of advisement from medical professionals to abstain from alcohol in that early post-injury period to reduce the likelihood of post-traumatic seizures. In some cases, it's limited access to alcohol, secondary to hospitalization, to living with family, or impairments of cognition and mobility that limit one's own ability to access alcohol. Many individuals who have an injury associated with intoxication will actually make a conscious decision to decrease or eliminate alcohol from their lifestyle. I have seen that many times where a person after a severe injury says, well, this is a wake-up call. I got to do something different. And they make a conscious decision to change. Some patients choose to stop permanently, but studies showed that approximately 25%, which is a fairly large subset relative to pre-injury numbers, are going to return to drinking. Again, it's a part of who a person is. It's something that it's a habit. And we'll talk about that and why it's difficult to change. Data has shown that incurring a TBI when you're younger, in childhood or adolescence, increases the likelihood of developing problem levels of alcohol use later in life. The concurrence of alcohol use also very high for some of the populations of individuals that are most vulnerable to TBI from a risk perspective. So again, young military veteran cohort, for example, that initial period of increased alcohol use after an injury can then, in some cases, be followed by a reduction to pre-injury levels long-term. But again, back to the level of what it was prior to injury often is the pattern. Psychosocial aspects that are associated with alcohol consumption after injury is, again, the first one relates to something that we previously reviewed, which is the best predictor of post-injury alcohol use is that of pre-injury alcohol use. We want to return back to our prior patterns and routines because they're familiar, and likely they were supported by the circumstances and the environment that we existed in. It's no surprise, therefore, that a return to pre-injury lifestyle is a typical goal, for better or for worse, for individuals that we are treating after an injury. Loss of access to activities or work or prior social connections after injury can also lead some people to turn to intoxication to deal with their loss. I've had patients previously tell me, I drink so that I can not think about these things that I don't want to think about. I drink so I don't have to think about the things I can't do. Alcohol as a treatment for depression is highly contraindicated because, as I mentioned a few slides ago, alcohol can actually worsen depression, independent of the negative issues that we've talked about earlier. It's like trying to put out a fire with gasoline. It's just not very effective, and it's going to result in the opposite of your intent. All this information leads to the recommendations, which is, again, a relatively simple answer, but the process is not. Reduce the risk. Abstaining is typically the recommendation. The way that TBI impacts one given individual is not a constant across the population of individuals who've sustained TBIs. And alcohol can present a lot of different risks we've covered here earlier. Given these factors, it's not possible to determine a safe level of alcohol intake for a given individual post-TBI. So most recommendations are to abstain entirely and to eliminate the risk, particularly that risk of unintended injury, which accompanies alcohol use. In the absence of abstinence, the next best thing you can do is cut back, to moderate and minimize alcohol intake. Again, it can be difficult to self-assess when and where to stop when you have cognitive limitations or impulse control issues. Having a TBI puts you at greater risk of having another TBI. Alcohol intoxication increases your risk of having another TBI. Add these two together, and your risk of having another TBI is greater if you can eliminate one of these factors. Because you can't go back in time and avoid the TBI, then the only remaining choice is to eliminate the other factor that increases the risk, and that's alcohol. So that, in this particular equation, is the only thing that you actually have control over. When it comes to making a change in alcohol intake, there's a variety of different recommendations, and like most habits and routines in our lives, as I said earlier, we tend to take them for granted. We accept them just as part of who we are. We integrate them into our sense of self, identity, and community. So the first steps to change really are becoming aware of the risk, becoming aware of the problem. Education involves learning the facts associated with alcohol, the risks. Changing your mindset associated with alcohol is a part of who you are and what you do. Awareness has to do with paying attention without judgment or criticism, but beginning to consider the possibility of abstinence even as an experiment. What if you just tried it for a day? Become aware of your own beliefs about these challenges. Support has to do with having somebody in your corner, having somebody backing you up, having a positive influence who shares your desire to make a change. It can be friends, family, it can be online support groups, strangers, organizations with a similar goal, etc. Skills and tactics. This is a big one because quitting any habit is hard. It is so automatic that you engage in the habit without any conscious thought or effort. So quitting alcohol is even more difficult, not only because it's an automatic part of your life, but there are physiological components to quitting that make it really hard. Headaches, disruption of sleep, unstable emotions, strong cravings that are both physiological and psychological in nature. You have to learn strategies and tactics to deal with these difficulties that will come when you attempt to reduce or eliminate alcohol, and even more so the more you have used alcohol. This includes establishing and keeping the right mindset for what you're capable of as well. The lifetime health benefits far outweigh the temporary discomforts. You also have to remember that we are not perfect individuals. No matter how strong your resolve is, you may not choose the right path every day, but you can learn from your mistakes. Figure out why things went off the rails and plan accordingly to avoid that in the future. Slip-ups and mistakes are actually useful in teaching ourselves life lessons if we use the information in a positive way. Doesn't mean that you're weak or you're bad if that happens, and it should be used as an opportunity to problem solve what went wrong and figure out how you can avoid it going wrong like that in the future. Look at what supports can make it likely. And to the question that was asked a little earlier, beyond just avoiding alcohol, studies show you can actually begin to reverse the damage in some aspects. We've talked about the negative physical effects that alcohol has on the body and on the brain. There was a research study in 2019 that was looking at the neural effects of exercise on the alcohol-damaged brain. So they were working with individuals who already showed indication of damage to the brain secondary to alcohol abuse, and what was the impact of exercise on that. The authors made a simple conclusion that alcohol has negative effects on brain health and exercise has positive effects on brain health. The mechanisms by which exercise benefit the brain directly counteract the mechanisms by which alcohol damages it. So exercise is increasingly being utilized as a component of treatment for alcohol use disorders because it represents a rewarding alcohol-free activity that can reduce cravings and improve comorbid conditions such as anxiety and depression. Our brain health is not separated from our body's health. Our brain is part of our body. If our body isn't healthy, our brain's not going to be healthy. Anything we do to improve our body's health improves our brain's health. I am often asked, what is the best thing that I can do to help improve my cognition? Or what's the best thing I can do to improve my emotional health? The answer to those questions is the same. Increase the amount of physical exercise that you are doing. Getting out and moving. Again, this is the PTs in the room are going to be really happy to hear this because their recommendations, the things that they are training you with, walking, getting outside, getting up and moving, do a little bit more every day, push yourself out of your comfort zone, just enough to start making a change. That is the single best recommendation I can give an individual who says, what can I do to help my cognition? Or what can I do to improve my mood? In this 2019 study, the authors noted that physical activity improves immune system function and decreases neuroinflammatory response. Exercise increases antioxidant activity and increases trophic support. Trophic factors or neurotrophic factors are proteins that have enormous therapeutic potential in the treatment of neurodegenerative diseases. That includes the potential of modifying neural dysfunctions. So in the presence of exercise, several neurotrophic factors are upregulated, and these act to control plasticity, cellular function, and maintain overall neural health. These positive effects have been shown initially in animal studies, and subsequently they've been borne out in human studies. Cellular changes can be seen in as little as 2 weeks of exercise, with increased synaptic efficiency following at around 2 months. So in other words, if you start an exercise program and stick with it, you're actually supporting positive neuroplasticity that can reverse some of the damage that is associated. The authors of this study concluded that the overall amount of physical activity, either whether from an active lifestyle or a regimented workout routine, was the most important factor considering in the brain benefits of exercise. So again, you don't have to go to the gym. You don't have to work out 6 hours a day. You just have to increase your physical activity, carrying laundry back and forth, going out and walking the dog, getting out in the sunshine and taking a walk. These are things that can help improve your brain's function and help reverse some of the aspects associated with injury. So the take-home message is be aware that alcohol and TBI are linked. If you drink, you're more likely to have a TBI. If you have a TBI, you're also more likely to drink. There's that bidirectional association. Alcohol use is associated with poorer long-term outcomes after TBI and increases your likelihood of having another TBI. Your conscious choices can change that risk. You can improve your brain health, your physical functioning, and your emotional health through regular exercise. So I will say thank you very much for sticking with me through this fire hose of information I've been spraying at you about alcohol and brain injury. There are some selected resources that I have within the handouts, and the handouts are available. Don and Steve, if you would, I would appreciate it if you could tack those on to the emails that go out to everyone. And now, if you would, why don't you hit us with that poll question, Steve?
You bet. So just a reminder, this is the poll question that you need to answer to obtain your CEUs. This is step 1. Step 2 will be responding to the email that we send you following this presentation. Again, that email is not going to come within minutes. It's probably coming within a couple hours. And to Jeff's point, when you fill out that review of this presentation, you will then get your CEUs, and tied to that will be the handouts of Jeff's presentation. So you will get that. So I'm going to launch the poll question. This is the only poll question. Please make sure to answer that. While we do the poll question, Jeff, a couple questions that have come through from the group. One being around naloxone. What are the interactions with naloxone to treat alcohol abuse in terms of how that might interact with ongoing alcohol use, if any?
Well, that is a really good question. I am not a physician, so I would not consider myself to be the expert to answer that particular question. But I do know, peripherally, some information about it. Basically, it is an opiate antagonist. It is something that is often prescribed for alcohol dependence, and it reduces, in theory, excessive alcohol consumption in animal models, and also has been shown to have a similar effect on individuals. I don't know directly, though, what use of alcohol on naloxone while being prescribed that. As I understand it, with some of those types of medications, they kind of create an aversive response when you drink with those, and so the aversive response being a physiological one. I don't know if that would be the case, and if there are any other experts online who can jump into chat and answer that question, I would be very appreciative as well.
Got it. Thank you. Another question around chronicity with drinking. It seems, I'm trying to make sense of it a little bit, but it seems like there's someone with pretty heavy use who's had multiple hemorrhages from a large cavernous malformation in the brainstem. Can you talk a little bit about the impact of, the fact that alcohol is a blood thinner on that related to the ongoing hemorrhages? Is there any connection to that?
Well, there is, and most definitely when you are looking at microvascular changes in an individual that you would typically see in a more elderly population, kind of a breakdown of some of the smaller capillaries within the midbrain and within the white matter of the brain. You will often see this in individuals who have the kind of trinity of risk factors, and that would be diabetes, obesity with accompanying hypertension, and alcohol use. When you combine the three of those, you almost are guaranteed to see microvascular changes within the white matter that should be anticipated for an individual with much advanced age. Again, age is not really the main risk for these things, but because it is such a good blood thinner, when you combine that with hypertension and diabetes and you get some breakdown of those small vessels, you are much more likely to have bleeds as a result because of the blood thinning nature of that. So again, it's contraindicated for an individual who has any type of a bleeding disorder to be on any type of medication that would be considered a blood thinner, except in very rare instances. So if you have hypertension and you're also drinking, then you have the risk there associated with higher pressure in those small capillaries, as well as the blood thinning if there is any type of a bleed. And again, combine that with diabetes, where you get some breakdown of those small capillaries, and you almost are guaranteed to have white matter changes and bleeds within the brain, much more common.
Thank you. We're down to the end. If you could get to this one real quick, and this will be the last question. What stage of TBI rehab do you begin educating the patient around alcohol use, especially with chronic use?
It depends on severity of the injury and their cognitive abilities. I would say for the vast majority of brain injuries, which are going to be mild to moderate in nature, it should be a part of the initial feedback from day one. Because you're going to have a very short period of time with that individual. So you want to provide as much education as quickly as you can. It really depends on the severity of prior use and severity of injury as to what is the appropriate response, but at least some level of education should be provided for all patients associated with TBI.
Take my medication.
Great.
And
All right, with that, Jeff, thank you again for such great information. Always a wealth of knowledge. Looks like we have a few folks who had issues with the poll question. If that is you, please email me or Don Terry. We'll get you squared away with that. All you got to do is let us know that you were here and you weren't able to answer it for whatever reason. Again, reminder, email to follow. That will include information to get your CEUs, and we'll send you the CEUs and the handouts. We will be back next month with a webinar on spinal cord injury and learning. So we will kick off the rest of our webinar series again next month with that, and we'll be here throughout the remainder of the year. So we look forward to that, and thank you all for joining us.